So physiology and pathophysiology of liver. So first, biochemical and physiological functions. That is what we have to deal with. The first important thing is the metabolic function. And among the metabolic function, the protein metabolism is very, very important. So how does the protein metabolism take place? The amino acids are converted into keto acids, glutamine and ammonia by either transamination or deamination in the liver. And the Krebs-Henselt cycle converts ammonia into urea. So liver failure with normal renal function will result in decrease in the blood urea nitrogen, but increase in ammonia. And this increase in ammonia is important for all the pathological changes that happen in the central nervous system, later on producing that hepatic coma, encephalopathy are all caused by the increase in the ammonia. And the liver-derived proteins are procoagulants, hormones, cytokines, chemokines, acute phase proteins, and transport proteins. And the albumin is produced in the liver about 12 to 15 grams per day. Total mass of albumin in health is 500 grams. And factors that affect albumin synthesis are plasma oncotic pressure, dietary intake of amino acids. And albumin not only provides the oncotic pressure to retain volume inside the vascular channel, but also it helps in the transportation of free fatty acid, unconjugated bilirubin, hormones, xenobiotics, and metals. And alpha fetoprotein, which resembles albumin, is genetically and functionally in the fetal life, but after 1 year of birth, this is replaced by the normal albumin, adult albumin, and the alpha fetoprotein values more than 400 nanograms is indicative of hepatocellular carcinoma in adults. So as a precursor, this point also needs to be mentioned. Now coming to carbohydrates, glycogen storage and breakdown mainly happen in the liver. The enzymes which are doing this function are glycogen synthase, which causes the glycogen formation, and glycogen phosphorylase, which causes the breakdown of glycogen. And the neoglucogenesis from non-glucose substrates like lactate, glycerol, alanine, glutamine, which are from protein in skeletal muscle, that also takes place mainly in the liver. So glycogen formation and breakdown as well as neoglucogenesis is a very, very important carbohydrate metabolic function of the liver. And hormones which cause release of glucose are catecholamines and cortisol and glucagon, and which act on the liver. Insulin causes a decrease in blood sugar by facilitating uptake of the glucose by the cells. Now coming to lipids, the liver stores the triglycerides, the fat as triglycerides or lipoprotein, mainly VLDL, that is very low density lipoprotein, by endocrine and nutritional factor support. And beta oxidation is the pathway for fatty acid catabolism. And glucagon increases this beta oxidation pathway, and insulin decreases that. And beta oxidation involves the use of acetyl-CoA. Now, bile metabolism mainly for bile is produced for absorption, transport, and secretion of lipids, and it also activates the lipases. And excretion of lipophilic substances by bile salts, which done by the bile. And bile salts are recycled through the enterohepatic circulation. And sphincter of OD spasm can happen by use of opiates in patients. And the drug which will release that spasm is, which drug will release the OD, sphincter of OD spasm after administering drugs like morphine? Rajini? Naloxone.
After morphine, sir.
After morphine or any opioid causing that, the naloxone is the drug of choice for relieving that spasm. And coagulation is the second function. So coagulants and procoagulants are synthesized in the liver, and protein regulators coagulation, C, S, and Z, and the plasmin activator inhibitor are also formed in the liver. And the role of protein Z is to degrade the factor 10A. And this protein Z and C, they are all the ones which keep the blood in a liquid form without going in for intravascular coagulation or thrombus formation. So these are all the regulators or restrictors of coagulation inside the vascular. If there is no endothelial injury, blood should always remain as a liquid without going in for any thrombus formation or accumulation of platelets and coagulation to happen. So that is mainly done by antithrombin 3 as well as this protein Z, C and SZ. So protein S is a cofactor for activator of protein C, which leads to inactivation of factor 8A in the 5A complex. So this is the mechanism by which they prevent the coagulation inside the vascular compartment when the blood is flowing. And decrease in protein S will lead to venous thrombosis, and decrease in plasminogen, plasmin activated inhibitor will cause uncontrolled fibrinolysis. And vitamin K cofactors, gamma carboxylation of glutamate residue is important for coagulation, and this function is blocked by your warfarin. And vitamin K dependent factors are 2, 7, 9 and 10, and protein C and S are also produced synthesized on vitamin K. And this gamma carboxylation helps the procoagulants to form complexes with calcium and other divalent cations. This primes the activation of serine proteases, and that is how the normal coagulation takes place. So by blocking that activity by using warfarin or acetylrome, we can prevent the thrombus formation and keep the blood in a liquid state. And erythropoiesis and erythrocytosis is another important physiological function. So liver is the main producer of RBCs in fetal life and early infancy until bone marrow takes over. But this function may reappear in cases of hemolytic anemia, marrow failure, and myeloproliferative diseases. And 20% of heme, even in adults, is produced by the liver. The rest only is by bone marrow for producing RBCs. And porphyrias can happen during heme formation, which is one of the aberrant pathways. And bilirubin metabolism happens by breakdown of effete or senescence RBCs, which have crossed their lifespan of 120 days. Their breakdown from which subsequent bilirubin formation takes place happens in the liver. And endocrine physiology, hormone metabolism happens in liver. Hormone binding proteins transport angiotensinogen, thrombopoietin, and insulin-like growth factor 1. All these are all transported by the liver proteins. And conversion of thyrotoxin, thyroxine to active 3T, trihydrothyronine, happens in the liver. And inactivation of aldosterone, ADH, estrogen, androgen, and insulin is also the main action in the liver. Then coming to immune and inflammatory response, super cells, which are modified macrophages, form the main defense against invading bacteria and toxins. So pro and anti-inflammatory cytokines are also formed in the liver. Drug metabolism and excretion, phase 1 and phase 2 reactions happen, and cytochrome family, cytochrome P50 family also play a major role in drug metabolism, which all happen in the liver. And liver is a reservoir of blood which can shift up to 1000 ml and be transferred due to sympathetic activation to safeguard during bleeding, either due to trauma or other causes. Now, so these are all the 7 important physiological functions that we have to mention. And we can notice that I have not mentioned anything about the blood supply, the division of hepatic artery or portal vein, or all these things come under the anatomical description. So the physiological functions, you can restrict your answer to this particular 7 headings. Now coming to the pathophysiology, how the cell death happens in liver. Mechanism of cell death. Hepatic cell death can happen due to hypoxia or anoxia, and necrosis due to failure of energy dependent ion pumps, and membrane dysfunction releases enzymes, reactive chemicals like aldehyde, lipid peroxidase, eicosanoids, and inflammatory cytokines. And apoptosis also happens because of these reasons, and also due to as a natural aging process. And what is the difference between necrosis and apoptosis? Anjani?
Apoptosis is programmed cell death, sir.
Very
Uh,
good.
ne
It can happen in
necrosis is
physiological conditions also. Okay. Whereas
yes,
necrosis is a pathological condition. It is
pathological.
uncontrolled. Whereas apoptosis is more under a controlled mechanism. Okay.
Yes,
And
sir.
what happens histologically? What is the difference that we will notice in necrosis and apoptosis? What will happen to the cells when you look them under the microscope?
Cell shrink,
Hmm?
swelling.
Necrosis will cause swelling and rupture of cell membrane and release of all the contents of cytoplasm into the circulation. Whereas
Yes,
apoptosis will cause shrinkage of the cell. And
yes,
of course, ultimately, the cell components also will be broken down, but it will not swell up. It will shrink and it will disintegrate. Okay? So
yes,
that
sir.
is the major difference that you have to know. And
Yes, sir.
oxidative stress and glutathione system is the second pathophysiology. So superoxide and hydrogen peroxide, these are the two agents which cause oxidative stress to compound, and their action is to break down the lipid membrane of the cells. So the membrane, there are a lot of functions for the cell membrane. They not only protect the cytoplasm and the nucleus of every cell, but also they have these ion pumps on their in between them, which are important for transport and transmission of substances outside and inside the cell. So the membrane dysfunction will happen, and the defense against this for preventing the oxidative stress are the micronutrients vitamin C and E, metal sequestering protein like ferritin, and the peroxidase and dismutase scavengers, glutathione peroxidase, which detoxified liver peroxidases, and thiol-rich groups like glutamine, which are important antioxidants. So these are all some of the normal mechanisms by which this oxidative stress is controlled. Then the third pathophysiology is the ischemia perfusion injury. This has been included in the pathophysiology because nowadays a lot of liver transplantations are being done, are being conducted in so many places. So we have to know that pathophysiology of ischemia and reperfusion also. This mainly produces necrosis maximally and to some extent apoptosis also, initiated by the reactive oxygen species. And the causes of this are supercell activation, xanthine oxidase formation, profusion of superoxide, nitric oxide, peroxides, and hydroxyl radicals, release of pro-inflammatory cytokines, and destruction of endothelial cells. So all these things lead to the ischemia reperfusion injury. And the preservative fluid that is used during liver transplant, that also can cause this problem by depletion of antioxidants, that is this uh, oxidative stress relieving drug, and also biochemical changes producing reactive oxygen species. And the hypothermia, the low temperature at which these perfusion fluids are injected into the organ, they can also cause endothelial damage. Then you can have extraneous inflammation or infection of the liver by bacteria, viral, and immune factors. So the endotoxin, which is nothing but a lipopolysaccharide complexes, cause direct or indirect cell injury. It can cause jaundice and its consequences. So all of us know that there are several types of viral infections, hepatitis A, B, C, D, etc. They all can produce cell destruction and jaundice. Now, drug-induced liver injury, the two mechanisms are either because of the excessive dosage, like paracetamol overdose can cause acute liver injury and liver failure, or it can be due to the idiosyncrasy of a particular drug. So that is the mechanism by which the drug injury can happen. And alcohol-induced liver injury is another pathophysiology which is common because of the chronic excessive alcohol consumption, which can lead to alcoholic cirrhosis. And subsequent to cirrhosis can be caused by other causes like nutritional and other viral infections. Hepatitis C can produce cirrhosis or malignancy, and also portal hypertension consequent of cirrhosis. And in portal hypertension, you will have the ascites, the other features like gradual liver function failure, and the subsequent ultimate causes of the various features of cirrhosis and portal hypertension will be described. But we need not go into too much of detail because we won't have time to complete the answer. And the cholestatic diseases, which can be classified as intrahepatic, where the intrahepatic canaliculi are all compressed, the bile gets into the bloodstream, or it can be an obstruction at the extrahepatic level due to the gallstones or biliary stenosis, and it can also be caused by the unconjugated bilirubin. It happens in excessive hemolysis and other conditions, which also come under extrahepatic causes. And fatty liver due to excessive deposition of fat in the liver, which is a very common finding in majority of our patients who undergo abdominal ultrasound nowadays. Invariably, you find there will be mentioned that there is a grade 1, grade 2 fatty liver in majority of the patients, which may unrestricted and untreated, it may also lead to fibrosis and cirrhosis of the liver. So even just mentioning the names of various pathological conditions is sufficient for completing the answer without going in for too much of details about portal hypertension and cirrhosis, etc. So these are all the other non-commonly known points which are given in your Miller. So this will be a better way of producing the answer for this particular question, which is nothing but a synopsis of what I have taken from the chapter on Miller about physiology and pathophysiology of hepatic. Okay.